Hi to you guys. Hi to everybody on Zoom. So we just want to have a short one today. I'm not going to go through too much. I actually, there's still quite a bit to cover in this toxicology series that we've been doing. All right. So the last time, I'm not sure if you guys were here when we did the opioids. That was in June. Okay. So anyway, if you have a chance, go back and watch that. All right. So we were talking about opioids, and prior to that, we had talked about how you go through, how you look at patients who are overdosing and your basic things like that. So we're just kind of carrying on with the things that, different types of common overdose drugs and, things like that. So there's still quite a few to do. So the one that we're looking at now is sympathomimetics, right? So already you can kind of understand from the name, sympathetic nervous system. And mimetics means that they basically attach to the same receptors. Okay, so in these days terms, uppers. Okay, if I say an upper, you want to take an upper, you understand what I'm trying to say, right? As compared to a downer and things like that, right? I don't know, maybe that's old language now. That was the language when I was young. Anyway. So what's happening is whenever you take a sympathomimetic, so can you think of any? I mean, the one is the cocaine, all right? But any others that you can think of? Sorry? No, atropine is what you call it, acetylcholine esterase, what you call it, agonist. So that's something else. No, I think along the lines of cocaine, right? Something that makes you high and happy and over the moon and things like that. So your guys watch Breaking Bad? All right, so what do they make? They meth, all right? So methamphetamines and things like that, right? It's not things like, all right, well, now you don't hear about it that much, but I know when we were young, there were things like mandrakes and all that. People also think those are actually different. Those are something that we call quaaludes. But sympathomimetics are things that basically mimic the actions of the sympathetic nervous system, right? So if you think about the sympathetic nervous system, it's basically a fight response. All right. So what happens? You get hot, you get angry, you start sweating, your pupils bulge. All right. You are basically ready for a fight. All right. So that's why cocaine is such a wonderful drug, they say. I've never tried. As much as I joke about it, but I've actually never tried. All right. But what it does, it gives people this sudden drive, all right? It gives them the sudden energy, all right? That's why methamphetamine does the same thing, I don't know if you guys have ever seen that meme about the guy who was on methamphetamine and managed to fight off 14 cops while masturbating at the same time. So it takes quite a bit of energy to do something like that, right? But that's basically what sympathomimetics do, all right? So they push your body into overdrive for a lot of time. So what's the problem with your body being in overdrive all the time? What is it going to affect? So number one, you're going to break down muscle much faster, all right? You're going to use up glucose much faster, all right? And which organ has to pump really hard to get all that blood everywhere is the heart, all right? So those are the ones that actually cause a problem. So that's what we're going to look at today, all right? And I'm not going to go too far into it, just to give you an idea of how you need to think about it, all right? So surprisingly, methamphetamine is actually on the rise in South Africa as well. Okay, across the globe, simply because it's a relatively cheap drug to produce. Okay, now this is not based on Breaking Bad. This is based on actual what we know, right? So the thing is, the ingredients that are used inside are relatively easily obtainable. The manufacturing process is relatively easy as compared to something like cocaine. Cocaine is a plant. It has to be processed, has to be grown, it has to be looked after. And with the synthetic things like ecstasy, although ecstasy is not a sympathomimetic, but what I'm saying is all of these lab-produced drugs are now coming out more and more. TIC is another good example of sympathomimetic. Even some of the ones, Nyawunga and all of that, not to a great extent, but it has elements of it inside. But all of these things, because they give people that ability to do a lot in a short space of time and be happy and just be running around and doing whatever they need to, especially at parties and things like that, that's why they're so popular. Because truth be told, if you're just sitting at home on a Saturday, you don't want to be in overdrive. You actually want to be chill. So you're going to pick up a nice joint, or you're going to take some Valium, or you're going to take alcohol and things like that to chill you out. But when you're going out and having a good time, you want something that can keep that party going. So that's where these drugs come in. All right. So that's why I say you get a hot, angry, sweaty, wide-eyed patient with chest pain, right? And that's really what they are. Let's just am I on the right one? Okay. So right, let's just close this for a second, just so that you can see that. So this is just a case history, all right? So a 45-year-old male with unknown medical history was taken into police custody under concern for trafficking illegal drugs. While he was back in the squad car, he told police he had swallowed a large amount of cocaine and may need to go to hospital. Not long afterwards, he became unresponsive. Paramedics were called to the scene. Paramedics found that the patient was minimally arousable. All right. Vital signs: respiratory rate 12, heart rate of 130, BP 140/69, SP over 295%. Temperature still relatively now, and this is your blood glucose level. So they work it out in the other one, so it's closer to, I think, 4 and I can't remember the exact now. I think it works out to something like 6 or something on our scale, right? So the cardiac monitor shows a sinus tachycardia, and then during transport, paramedics witnessed tonic-clonic seizure activity, right? 2 milligrams of IV lorazepam or Ativan. On arrival in the emergency department, airway is intact, respirations are shallow, there's no response to anything else, all right? So this guy is obviously, and with the drug mule situation, even though not so much in South Africa, but drug muling is common across the world, this is a relatively common scenario. Okay, so the reason I'm not going to trouble you all on the ECG, we're not going to sit and analyze. I just wanted to make the point of how important ECGs are in this whole thing. All right, so let me just get, let me see if the spotlight will work a bit better. Right, hopefully the guys will see it. All right, so the main thing that we see over here is, yes, this is where you could argue that it's a sinus tachycardia, maybe even a SVT, things like that. But if you were to see this in a patient, you would immediately be worried. Agreed. So even though we're not going to delve too much into what cocaine does, but I just want to show you how important the ECG is, right? So this was the initial ECG that was done on this patient, right? Now, even after I had gone through the case and had a look at it, then they talk about the sinus tachycardia, toxicological widening of QRS, things like that, which you can see as well to a little bit of an extent. So, like I say, this patient is in overdrive. Their heart is pumping at, well, here it's even beyond 130. It's coming closer to 150 now, beats per minute, all right? Patient is unresponsive or poorly responsive. What are you going to do? Okay, so I told you I'm not going to trouble you all with questions, so don't stress, all right? I just wanted, if you all gave me an idea. So in other words, you've got a patient where you know what the problem is. So as compared to somebody who walks into your unit and you have no idea why their ECG looks like this. Is it a hyperkalemia? Do they have underlying cardiac disease? Has this patient had trauma? No, you know this patient took cocaine. They told you before they passed out, I took cocaine. So you expect to see this. So the question is, if you know what's causing the problem, how do you sort it out? You give the antidote. So it doesn't matter what the patient has taken. You give the antidote to that. So for example, if the patient had taken opiates, tramadol, for example, is something we give out very commonly. Somebody took 40 tramadol, and now their heart rate is 27. You are not going to trouble yourself too much with giving them atropine and trying to give them adrenaline and trying to pick up their heart rate with pacing and things like that. You'll be better served by giving them the antidote to the opiate. Same story with a patient who takes Valium, or a patient who comes in and you know they've taken organophosphates, you know what you're going to do. Do you get what I'm trying to say, right? So the ECG is one of your best tools when it comes to toxicology. Okay, so just do that, right? So the patient was given 200 milliequals of sodium bicarbonate, all right? So the question may come, how do you know how much to work out? You guys have seen the sodium bicarbonate we have over here? Okay, have a look at it, all right? So you get 8.5% and 4%. Basically 8.5%, 1 mil is equal to 1 milliequal. And we normally give per kilo 1 to 2 milliequals. So let's say, for example, somebody's 100 kilos, you would give them 100 mils or 200 mils. If you had 4%, then it's half a milliequal per mil. So you would give them double that amount, all right? So that's basically how it works, okay? Morning, Esther, how are you? I'm just muting you because we can just hear the background noise from you, but you're more than welcome to unmute if you need to tell us anything, all right? So what we've noticed over here as well is that the QRSs have now started to slow down. And if you compare the first one to the second one, there's not a huge change. but it actually looks just a little bit better. The heart rate's just slowed down a little bit, and they're using this to actually monitor and see what's happening to the patient, all right? So this patient was given an additional 200 milliequals of sodium bicarb. The patient is started on a sodium bicarb drip, 150 milliequals in 1,000 mils at 150 mils per hour. The question remains, why? Don't stress about that right now. You do give Sodabic. You have to work it out based on the patient that you've got in front of you. If you were not sure, this is the type of patient that you would either phone the Tox Center about, or if you had access to the online program, you would go into that, and it gives you all the formulas. The reason why I'm not concentrating on it is because you remember it about cocaine, but you won't remember it about another drug, how much you give for that. So I don't want to get stuck on it for now, right? So they started giving the antidote. And after giving the antidote for quite some time, this is what they eventually ended up. Okay, so the patient started to settle down, all right? So this patient's heart rate started to normalize. And then what happened, and especially with cocaine, can you see these ST elevations and ST depressions that are all over here? So what happens with cocaine is it actually causes a vasospasm in the coronary arteries. So these arteries close down and they actually cause an ischemia. But the ischemia is not because of blockage. The ischemia is because of physical narrowing. You know, the actual, vessel has now narrowed. So the thing is with these patients, and pray that you never get one of these patients, they're very difficult actually to control and to treat. We would normally give our ischemia patients thrombolysis. So we'd give them something like alteplase or streptokinase, things like that. It doesn't work because the problem is not a clot. So breaking down clots doesn't help. You have to physically enlarge that vessel. So that is with PCI, balloon insufflation, right? Percutaneous coronary insufflation, which we don't even have yet. Madadenia and most hospitals don't have. We have to refer the patient to a tertiary center. Okay. Now, actually, in most cases in our setting, we'd actually keep an eye on the patient, see if they resolve, how they respond to the antidote and things like that. But if you were in a big center, you would just take them and do the PCI, and that's it, right? But just so that you guys can see that by giving the antidote and by monitoring the ECG, you can actually see what a difference, what a difference there is on the patient, okay? So how do you manage the symptoms of an overdose of sympathomimetics, all right? So as I told you, the body is in overdrive. So when your body is in overdrive, you start to use up all your sugar stores, right? All your glucose stores. So you have to keep on checking glucose, all right? Because like I say, this patient's body is just using up everything. The way you've got to imagine running uphill on a treadmill. You know, in the treadmills at its steepest, on its, let's say, 12 or 13 Ks an hour. So imagine doing that. You know, you're just going to run out of energy in no time. That's basically what the body is doing. So you have to check your glucose levels, all right? Now, these patients do often have myocardial infarctions. It's more common with cocaine, but they do see it with methamphetamines as well and some of the other sympathomimetics. And like I say, because the problem is not a clot, the problem is the actual constriction of the vessels. They very often need to be dilated, all right? But this is where the problem comes about. So you have a patient who is hot, angry, and violent. That's why I say pray that you never get to. We had one of these patients about 3 years ago. It wasn't fun. I can tell you that much, right? Because not only have they taken a drug, they've taken a large amount of a drug. So not only are they in overdrive, they are in extreme overdrive, right? So imagine, you've seen all our psychiatric patients that come in here. I'd say about 4 to 5 times worse than even the worst one that you've seen over here, all right? Now, the one guy who we had, amazingly, not just a cocaine junkie, steroid junkie as well. So in other words, if the 3 of us were to stand by him next to one another, I think we just make up the size of his back. That's how huge he was, right? It took 16 of us to hold him down. 16. Now that I'm talking about nurses, doctors, and you've seen some of the doctors who work here. They guys who go to gym and things like that, security guards, and it took 16 of us to hold him down, right? And in the meantime, he's having STEMIs all over the place. He's trying to hit us. He doesn't know what's going on. So we had to restrain this guy, sedate him. We gave him as much benzos as we could just to keep him down. And the thing was, he was hypothermic, right? To the point where it could have been dangerous, right? So we had to physically cool him. In his case, I remember he was actually transferred down to Grays because we couldn't, he didn't respond to the medication that we had given. He had taken that much, right? He and his girlfriend had been on a bender the whole weekend. So it wasn't a good sign, right? So I know you guys weren't here for the previous one, but what we were doing was we were actually comparing basically what we call toxidromes, all right? So a toxidrome is a syndrome in toxicology, okay? So if you have a chance, watch that. So what happens is it's sort of like a yin and yang. So for example, if you take organophosphates, they give you a certain effect. And then if you take atropine, it gives you the exact opposite effect. So there's often a type of drug that does one thing and another drug that does the complete opposite. So you have to know both, okay? So opioids are one type of drug and sympathomimetics are the other type of drug. So this is the yin and this is the yang. Opioids, basically, you're trying to chill out as much as possible. Sympathomimetics, so for example, morphine, heroin, any type of opioid is trying to make you relax, chill out. Whereas cocaine is trying to make you as hyped up as possible. So what happens is, if you can remember one set of symptoms, it becomes very easy when you see the complete opposite set to remember what's going on, right? So in previous ones, we had contrasted, for example, organophosphates with, or let's say inhibitors with agonists. So atropine and tricyclic antidepressants, we had contrasted with organophosphates, for example. So we're doing it again. So if we were to look at this, right, so imagine we can't see this. So we know that opioids and sympathomimetics are the complete opposite of one another. So if opioids give you bradycardia, we expect that one to give you tachycardia. If morphine and heroin give you bradypnea, which is slow breathing rate, then you'd expect cocaine to give you the exact opposite. Morphine and heroin give you low BPs or hypotension. So cocaine gives you hypertension. These patients are cold because they're not perfusing their peripheries. These patients are hot because they're over-perfusing their peripheries. These patients have small pupils. These patients have exceptionally large pupils. These patients are absolutely chilled. These patients are absolutely hyped up. Okay, so that's how we kind of have to contrast all of these patients whenever we look at. Okay, so that's another toxic. So we've still got a few minutes. Let me see if we can cover another one. Right. So we just want to talk about benzodiazepines. Right? So do you guys know any benzodiazepines? Should. We use them all the time to treat our epileptic patients, especially when they just come in. So things like Ativan, Valium, Tomicum. So anything that chills the brain out, right, is a benzodiazepine, right? So benzodiazepines are relatively easy to acquire, really. On prescriptions, via the back door, there's a huge black market for benzodiazepines. The nice part about benzodiazepines is that they are taken by people who just want to escape, if you get what I mean. They just don't want to be involved with the world. They want to sleep. They want to I would say it's similar to opioids. I haven't tried all of these things, but I'm just guessing, right? But essentially, your benzodiazepines, if you can think about it, it's just basically to shut your brain down. You want to sleep, all right? So most of the drugs that we use, for example, like I say, Tomicum, Ativan, the main thing that we're trying to achieve in the patient is sedation. So you're trying to make yourself as sedate as possible. That's what this patient is trying to achieve, all right? Now with opioids, there's a different aspect with it, that there's a relative euphoria that comes out with opioids as well. People feel happy, even though they chilled, but they feel happy. Benzodiazepines, there's not so much of the euphoria part of it. It's more just the chilling out part of it. So a lot of these drugs are often used in conjunction with one another, all right? So what do you expect to see? So even before you look at this, all right, before you look at this, if you were to give a patient Ativan, and you guys have worked in our department as well, what would you expect the patient to do? Number one, sleep. Number two, how would their speech patterns be? Slow, relaxed, chilled out, agreed. So we're talking about all of these, right? So ataxic, you wouldn't expect, you keep them on the bed because if you know that they walk, they're going to fall down, all right? They are confused, and they often are. Take somebody on Ativan and ask them, what's 10 plus 10? Yeah, what's 10? Yeah, they don't know what you're talking about. Yeah, is it the 10th of what? Nystagmus. Right? So you guys have seen nystagmus? So nystagmus is the shaking of the eye when the patient looks to either side, right? So you get lateral, medial, what you call it. There's a few types of nystagmus, but basically when the patient looking and the eye starts to vibrate, right? So that's nystagmus. But generally nystagmus occurs when you really started to overdose on these drugs, right? And then respiratory and cardiac depression, right? So in other words, slow breathing rate, slow heart rate, especially if taken with alcohol. And unfortunately, most benzodiazepines that are used are taken with alcohol. Benzodiazepines are an odd one because often patients develop large amounts of tolerance, even with opiates as well. So for example, you've got, all right, let's say we've got Mrs. Smith, whose husband goes golfing every weekend and is always busy with the secretary. But Mrs. Smith knows that she's got a good life. So Mrs. Smith doesn't want to leave her husband, but everything's taking its toll on her. Mrs. Smith is the perfect candidate for taking benzodiazepine. She's got a sherry or a vodka in the one hand, and she's popping pills all the time. This is not a scenario that's difficult to imagine. And this is generally the scenario that happens. So the first time Mrs. Smith goes to a doctor and says, you know what, I'm having trouble sleeping, this and that. Dr. Mohammed says, no problem, Mrs. Smith, here you go. Try this Valium at night. So initially when Mrs. Smith takes it, for the first month, 2 months as well, she's just taking that single Valium and it's okay. And at the end of 2 months, hey, one Valium's not doing it anymore. And in fact, I need to start taking one in the morning as well, just to try and get me through the day. After a year, Mrs. Smith is having one at breakfast time, one at mid-morning, second lunch, third. You get what I'm saying? So they build up this huge tolerance, and they can actually be quite functional as well. So it's very rare to see a benzodiazepine overdose that involves very small amounts, unless it's an acute overdose. So in other words, I decided I want to kill myself, somebody's got Valium lying around and I go and take it, right? So in that case, a smaller amount was the problem. So a lot of the patients who do end up overdosing have actually been on it for long periods of time and have developed a huge tolerance to this. I'm just mentioning this, the reason being that when you tackle these patients, you may be wondering why they're not coming out of it, or why are they experiencing such severe side effects when you do try to take them out of it. So there's just something to keep in mind, all right? Okay, so what do we do in terms of these patients? So for these patients, it's mainly supportive, all right? There is an antidote, which is flumazenol, right? It goes by a couple of names, but the chemical name is flumazenol, right? So flumazenol ideally is only given in a high care setting. Now, flumazenol, you will, for example, if you work in orthopedics or you work in surgery where they do short cases and there's just a need for a bit of sedation, they do give benzos and then give a small amount of flumazenol. The reason being that it's a controlled thing, right? So they take the patient in and out quickly. When it comes to an overdose setting, the reason why we don't do that, and you'll see we don't keep it in A&E as well because we don't want anybody to do it by mistake. As I've told you, these patients have had a long history of taking it, generally, right? So what do we treat normally with these things? Is things like seizures, severe psychosis, things like that. So it works on a particular part of the brain, particularly the GABA system and things like that. So those types of things are now being controlled, if I can put it that way, by this drug that this patient has been taking for a long time. So what happens is if you give them flumazenol outside of a high care setting, you can very easily initiate an acute withdrawal syndrome. And what happens during the acute withdrawal syndrome is that you suddenly put their body into a state of shock. They start seizing, they become hypertensive, malignantly hyperthermic, tachycardic to the point of extreme, all right? So it has to be given a very controlled setting. In other words, you're going to give them a little bit, see how they react. Give them a little bit, see how they react. And at the same time, you've got them ventilated, you've got them monitored. So you're making sure that you're taking them out of it in such a way that their body can manage it as well, all right? And that's the reason why it's used. Okay, so I have seen in 1 or 2 places that they do still keep it in the emergency trolleys, but a lot of places have moved away from that, right? So what happens if your patient does have a seizure? Which can happen. I mean, it happens with our cocaine patients, it happens with so many patients. What do you do? And we're going to stop here. This is the last thing. We'll carry on here next week again. In fact, what do you do for your patient who's even had benzos and is now seizing? You give them benzos. You have to stop the seizures. Basically, that's the thing. And unfortunately, seizures are quite common in poison patients. They do happen quite often, right? The thing is, there's such a wide range of toxins that can be used. There's such a wide range of drugs. There's such a wide range of substances. There's so much new things that are being developed. So very often patients may take large amounts, sometimes unknowingly as well. I mean, to give you an example, you go to a party tonight. It's Friday night. Somebody offers you something. All right, you're going to try it out. But there's nothing on there. It doesn't tell you how many milligrams. There's no directions for use, pharmacokinetics, contraindication. There's no leaflet that comes with that thing. So you have no idea what they're really giving you. So a lot of the times, because it has a central nervous system effect, which is essentially what you're trying to do when you take drugs specifically, you're not trying to make your little finger feel good. You're trying to make your brain feel good. So with anything that interferes with the brain, there's a possibility for complications. All right. So seizures are common for a few reasons. Number one, effects on the actual, transmission systems. So for example, like I say, your hypothalamus, your GABA system, there's so many things that can go off, cortical stimulation, things like that. But cerebral stimulation. Then, of course, there's other effects, such as vascular effects. So vascular dilation, vascular constriction on the brain, edema, bleeding tendencies. So there's a lot of things that happen in these patients that can lead to seizures. Most commonly is tonic-clonic. The reason being, most of these things have a global effect on the brain, but you can have focal neurology as well, right? With certain drugs, not all of them, but with certain drugs and certain substances, okay? So it's just something to keep in mind. Now, I'm going to stop there because there's another slide that has quite a bit that I want to speak about, and I don't want to start with it now because I've got to get to my meeting in 4 minutes. So I'm not sure if you guys have any questions at the moment. If there's anything I want to know right now. Okay, so we're going to stop right there. Hopefully next week will be our last one or second last one, and then we can finish off with the basics, because literally all we've done is the basics. Literally, you can have a week's lectures just on cocaine, just 1 week on Ativan, 1 week on Valium, 1 week on that. It's so in-depth that you can go in when you really get into it, but we'll stop there for now, right? If there are any questions, you guys are more than welcome to ask me. Otherwise, we'll just stop for now. And yeah, we'll carry on. Next week, Monday is a holiday. Yes, so we'll carry on Wednesday with everything. Okay, right. Thanks. All right, no problem.